A 45-year-old patient with high-risk leukemia is admitted to the emergency department following their first round of chemotherapy. Their laboratory results show elevated potassium 5.8 mol, uric acid 12.0 DDL, and phosphate 8.5 mdl. What immediate interventions should be performed to manage potential tumor lysis syndrome (TLS) in this patient, and what laboratory abnormalities should be monitored closely during management? Answer: tumor lysis syndrome (TLS) is a life-threatening condition that can occur after the initiation of chemotherapy, especially in patients with high-risk hematologic malignancies such as leukemia and lymphoma. It results from the rapid breakdown of tumor cells, leading to the release of intracellular contents like potassium, phosphate, and nucleic acids. These can cause serious complications such as hyperkalemia, hyperphosphatemia, hyperuricemia, and acute kidney injury (IKI). The immediate management of TLS includes aggressive hydration to help flush out the released intracellular contents and prevent kidney injury. This is typically done with normal saline or isotonic fluids, allopurinol, to inhibit the formation of uric acid, which can precipitate in the kidneys and lead to AKI. Rasburicase, an alternative to allopurinol, especially if the patient has high uric acid levels, as it helps break down uric acid into allantoin, which is more easily excreted by the kidneys. Monitoring. Electrolytes. Regularly monitor potassium, phosphorus, calcium, and uric acid levels to assess for improvement or worsening of the condition. Renal function. Closely monitor creatinine and urine output for signs of AKI. Cardiac monitoring. For the development of arrhythmias secondary to hyperkalemia. Mr. Thompson, a 58-year-old male with a history of hypertension, presents to the emergency department with sudden onset of severe eye pain, blurred vision, and the perception of halos around lights. He reports that the symptoms have progressively worsened over the past few hours. On examination, his eye pressure is measured at 4 mmHg, and he shows signs of conjunctival redness. Based on these findings, what is the most likely diagnosis and what immediate treatment should be initiated? Answer: the most likely diagnosis in this case is acute angle closure glaucoma, a medical emergency characterized by a rapid increase in intraocular pressure due to obstruction of the anterior chamber angle, which impedes the outflow of aqueous humor. Symptoms typically include severe eye pain, blurred vision, halos around lights, and conjunctival redness. Immediate management should include intraocular pressure reduction. This can be achieved with medications such as acetazolamide, a carbonic anhydrase inhibitor, to decrease aqueous humor production, beta blockers e.g. timolol to reduce the production of aqueous humor, prostaglandins e.g. latanoprost to increase outflow in some cases, hyperosmotic agents e.g. mannitol in severe cases to rapidly lower intraocular pressure, referral for surgical intervention. After the pressure has been controlled, the patient should be referred for laser iridotomy, which is a definitive treatment to create a hole in the peripheral iris, allowing aqueous humor to drain freely. Key point: acute angle closure glaucoma is a true ophthalmologic emergency and requires prompt treatment to avoid permanent vision loss. In the management of a patient with sickle cell disease presenting with acute chest syndrome, what is the most important first-line intervention to improve oxygenation and prevent further complications? Answer: acute chest syndrome acts as a potentially life-threatening complication of sickle cell disease, often precipitated by infection or vaso-occlusion in the lungs. The primary treatment focus is improving oxygenation and preventing further sickling of red blood cells. First-line interventions include oxygen therapy to prevent hypoxia, which can exacerbate sickling and worsen ACS. Hydration. Intravenous fluids help to reduce blood viscosity and improve circulation. Pain management. Adequate pain control, usually opioids, is crucial for preventing further vaso-occlusion. Antibiotics. If infection is suspected as a trigger for ACS, e.g. pneumonia, empiric antibiotic therapy is initiated. Blood transfusions. In cases of severe anemia or if ACS does not respond to other treatments, transfusion therapy is often employed to reduce the proportion of sickle cells in circulation. A 30-year-old patient arrives at the emergency department following a fall and a tooth has been completely avulsed. What is the most appropriate management for this patient to optimize the chances of reimplantation of the avulsed tooth? Answer: for a dental avulsion, the most important factor in successful reimplantation is time. The tooth should ideally be reimplanted within 30 minutes to 1 hour after the injury, but it may still be viable if stored properly and reimplanted within a few hours. The correct management includes reimplantation. If possible, the tooth should be immediately reimplanted by the healthcare provider. If the patient is unable to reimplant the tooth, it should be kept moist. Storage medium. The tooth should be placed in a moist environment. such as milk ideal as it maintains the viability of the tooth cells. Saline solution, saliva if milk or saline is unavailable. Avoid storing in water as it can damage the tooth cells. Referral to a dentist. The patient should be referred to a dentist for further care, including stabilization and potential root canal therapy. Which of the following is the most appropriate initial management for pain relief in a patient with sickle cell disease presenting with a vaso-occlusive crisis? Answer: the correct initial management for pain relief in a patient with sickle cell disease during a vaso-occlusive crisis is opioid analgesics. Opioids, such as morphine or hydromorphone, are the most effective medications for managing severe pain during a crisis. Key management steps: pain control. Start with opioids for moderate to severe pain. Non-steroidal anti-inflammatory drugs, NSAIDs like ibuprofen, can be used for mild pain. Hydration. Intravenous fluids help reduce blood viscosity and prevent further sickling. Oxygen therapy. Administer oxygen if the patient is hypoxic. A patient arrives at the emergency department presenting with symptoms of a potential biological threat, e.g. anthrax. What personal protective equipment, PPE, would you select to ensure the safety of both the healthcare worker and other patients? Provide an explanation of the reasoning behind your choices. Answer: in the event of a biological exposure such as anthrax, it is crucial to protect against airborne pathogens and direct contact with potentially contaminated fluids. The recommended PPE would include N respirator or higher. This protects against inhalation of small airborne particles, including spores from anthrax. Gloves, to protect against direct contact with contaminated fluids. Gown. A gown would protect against contamination of skin and clothing, especially if there is any potential for the patient to vomit or have fluids leak. Eye protection. Goggles or face shields are used to protect the eyes from splashes or aerosolized particles. Proper donning and doffing techniques must be strictly followed to avoid contamination. Always don the PPE before contact with the patient and remove it following protocols to ensure proper decontamination. MS Williams, a 17-year-old patient, comes to the emergency department with signs of severe physical abuse. She is hesitant to speak about her injuries and requests that her parents not be informed. What should you, as an emergency nurse, do in this situation to uphold both legal and ethical standards? Answer: as a minor MS, Williams is still under legal protection, and in most jurisdictions, healthcare providers are required to report suspected cases of abuse or neglect to the appropriate authorities. The Child Abuse Prevention and Treatment Act (CAPTE) requires healthcare professionals to report such incidents to protect the welfare of the child, even if the patient requests confidentiality. However, it is also important to explain to MS Williams that while you respect her wishes, you are legally mandated to report the abuse. It is crucial to maintain her dignity and trust throughout the process, offering emotional support and possibly involving a social worker to assist in managing the disclosure, documentation of the incident, and the steps taken, including attempts to contact appropriate agencies, is critical. Mr. Miller, a healthcare worker, is treating a patient who has been exposed to a chemical agent. What steps should Mr. Miller take to protect himself from exposure and ensure the patient is safely decontaminated? Answer: Mr. Miller must follow the CDC Centers for Disease Control and Prevention guidelines for chemical exposure. The steps are: don appropriate PPE. Mr. Miller should wear full PPE, including chemical-resistant gloves, a gown, and NIOSH-approved respirator and eye protection. Ensure patient decontamination. Before entering the patient's room, a decontamination zone should be established to strip away contaminated clothing and rinse the patient with copious amounts of water if necessary. Isolate the patient. If the chemical agent is highly toxic, Mr. Miller must ensure that the patient is isolated and their exposure minimized. He should also ensure that any spillages are contained and reported. Proper doffing techniques. After the treatment is complete, he must carefully remove all PPE to avoid contamination, following proper protocols for decontamination of both the patient and himself. Explain how the SALT SORT assess life-saving interventions. Treatment transport triage system differs from START, and in what type of mass casualty incidents each system would be most useful. Answer: the SALT triage system is a more advanced system compared to START, designed for large-scale incidents where triage decisions need to be made quickly, so patients are grouped based on the severity of their injuries. Assess: critical assessment of the patient's airway, breathing, circulation, and neurological status. Life-saving interventions. Immediate life-saving interventions are performed where necessary, such as opening the airway or controlling hemorrhaging. Treatment transport. Patients are categorized for immediate transport to treatment facilities based on the resources available. START, on the other hand, is simpler and focuses primarily on categorizing patients based on their immediate needs for treatment: red, yellow, green, or black. The SALT system is especially useful in incidents involving a large number of casualties with varied injury types and when resources are stretched, while START is appropriate for smaller incidents or where the emergency department is handling limited casualties. A patient with severe injuries refuses treatment even though it is necessary for his survival. How should you approach this situation, and what are the legal and ethical implications of respecting his refusal? Answer: in cases where a competent patient refuses treatment, the principle of autonomy dictates that their decision must be respected. However, the nurse should ensure that the patient fully understands the consequences of refusing care. If the patient is competent and informed, the refusal of care is legal under the Patient Self-Determination Act and should be documented. If the patient is not competent, e.g., unconscious or incoherent, implied consent would apply. In situations involving minors or individuals who lack the capacity to make decisions, the healthcare provider may need to involve legal guardians or social services to make a decision on their behalf. Additionally, ensuring that the patient's informed refusal is documented is essential to protect both the patient's and provider's rights. What are the key components of advanced cardiovascular life support (ACLS) when managing ventricular fibrillation (VF), and how does defibrillation contribute to the stabilization process? Answer: ACLS guidelines emphasize the rapid recognition and treatment of cardiac arrest, particularly in cases of ventricular fibrillation (VF). The key components include early recognition of VF, immediate assessment of the patient's condition, identifying VF on the monitor, defibrillation, the cornerstone of VF treatment. A shock is delivered to the heart to restore a normal rhythm. High-energy shocks, 200-360 joules, are recommended, and synchronized cardioversion is used in certain situations where the arrhythmia is identified. Chest compressions. Continuous chest compressions are essential while preparing for defibrillation. Post-cardiac arrest care, hemodynamic stabilization, including targeted temperature management (TTM), is crucial to improving survival outcomes. Defibrillation works by delivering a high-energy shock to the heart, disrupting the chaotic electrical activity (VF) and allowing the normal pacemaker cells to resume control of the heart's rhythm. What are the primary differences in the approach to treating pediatric cardiac arrest versus adult cardiac arrest in pediatric advanced life support (PALS? Answer: the approach to pediatric cardiac arrest in PALS differs from adult care in the following key aspects. Primary causes of arrest. In children, respiratory issues, e.g., asthma, choking, are more commonly the cause of arrest compared to adults, where it is often due to underlying cardiac disease. Airway management. Pediatric patients require age-appropriate airway management, including the use of different sizes of endotracheal tubes and bag valve mask ventilation techniques. Medication dosages. Pediatric doses are significantly lower than adult doses. Drugs such as epinephrine and amiodarone are dosed based on weight, and practitioners must refer to specific charts for pediatric resuscitation dosing. Chest compressions. The compression depth in infants and children differs. 1-3 The depth of the chest and compression rates are adjusted. 100-120 per minute for children. Relevant guidelines. The American Heart Association, AHA Pediatric Advanced Life Support (PALS) guidelines outline these differences clearly. Mr. Taylor, a 65-year-old male, presents with severe chest pain, shortness of breath, and confusion. His blood pressure is 90/60 mmHg and his heart rate is elevated at 120 bpm. What should the emergency nurse suspect, and what is the most appropriate immediate action? Answer: Mr. Taylor is presenting with signs that are highly suggestive of cardiogenic shock, likely secondary to myocardial infarction. The combination of chest pain, no blood pressure, tachycardia, and altered mental status points to insufficient cardiac output, leading to inadequate tissue perfusion. Initial assessment. The nurse should immediately assess the patient's airway, breathing, and circulation. Continuous monitoring of vital signs is essential. Diagnostic tests. Electrocardiogram to confirm if the patient is experiencing a ST, MI elevation myocardial infarction. Blood tests including troponins will help confirm cardiac damage. Immediate intervention. The priority is to administer oxygen, establish intravenous access, and provide aspirin for antiplatelet therapy. Administering nitroglycerin and/or morphine may be appropriate depending on blood pressure and clinical condition. Prepare for potential defibrillation if arrhythmias are detected. Fluid resuscitation. Care must be taken to avoid overloading the patient with fluids, as this can exacerbate pulmonary edema and cardiogenic shock. What is the role of targeted temperature management, (TTM), in post-cardiac arrest care, and what evidence supports its use? Answer: Targeted temperature management, (TTM), is a therapeutic strategy used to improve survival and neurological outcomes in patients who have experienced a cardiac arrest. The core concept is to cool the patient's body to between 30 Tudic and 36 Dic, typically achieved through external cooling techniques such as cooling blankets or ice packs for a period of 12 to 24 hours after resuscitation. Mechanism: cooling the brain helps to reduce metabolic demand, protect neurons, and reduce the cascade of cellular injury and inflammation that can lead to secondary brain damage. Evidence: studies including the HACA trial, hypothermia after cardiac arrest, have shown that induced hypothermia improves neurological outcomes in patients who are comatose after return of spontaneous circulation. ROS relevant guidelines. The HA post-cardiac arrest care guidelines recommend TTM for comatose survivors of cardiac arrest. How does the management of traumatic brain injury (TBI) differ from other types of head injuries in an emergency setting? Answer: traumatic brain injury (TBI) requires immediate and specific management to prevent secondary brain injury. Key principles include initial assessment. The Glasgow Coma Scale (GCS) is used to assess the severity of the injury, where scores below 8 indicate a severe injury. A GCS of 3, 8 suggests coma and requires urgent intervention. Intracranial pressure management. If ICP is elevated, e.g. from cerebral edema, strategies such as head elevation, hyperventilation, and osmotic therapy. G. Mannitol or hypertonic saline are employed to decrease ICP. Neuroprotective strategies, minimizing hypoxia and hypotension is critical, as both are key contributors to secondary brain injury. Relevant guidelines. The Brain Trauma Foundation (BTF) guidelines for managing severe TBI provide a detailed protocol for maintaining adequate cerebral perfusion pressure and controlling ICP. How is the FAST focused assessment with sonography for trauma exam used to assess abdominal trauma, and what are its limitations? Answer: the FAST exam is a rapid, non-invasive ultrasound assessment used to detect free fluid, blood, in the peritoneal cavity following abdominal trauma. It is performed in the emergency department to quickly identify patients who may require surgical intervention. Procedure: the FAST exam involves ultrasound of 4 areas: the pericardial space, right upper quadrant, left upper quadrant, lung and pelvis. Limitations: the FAST exam is highly sensitive for detecting hemoperitoneuum, but may miss smaller amounts of fluid or injuries to retroperitoneal organs, e.g. kidneys, pancreas. It is also limited in detecting solid organ injuries that do not result in fluid accumulation. Relevant guidelines. The ATLS Advanced Trauma Life Support Guidelines incorporate FAST as an essential tool for rapid trauma assessment. In the case of attention pneumothorax, what are the steps involved in needle decompression and why is it essential? Answer: attention pneumothorax occurs when air accumulates in the pleural space, leading to increased intrathoracic pressure, which impedes venous return to the heart and reduces cardiac output. Immediate intervention is required to prevent death. Needle decompression. The standard approach involves inserting a large bore needle 1/4-1/6 gauge into the second intercostal space midclavicular line on the affected side. This allows the trapped air to escape, relieving the pressure. Chest tube placement. Following needle decompression, a chest tube is typically placed to continuously evacuate air and prevent the reaccumulation of pressure. Relevant guidelines. The ATLS guidelines and ACLS protocols emphasize the need for early recognition and immediate decompression of tension pneumothorax. What is compartment syndrome, and why is early recognition critical in the management of orthopedic trauma? Answer: compartment syndrome occurs when increased pressure within a muscle compartment reduces blood flow, leading to ischemia and potential necrosis of tissues. This can occur after fractures, particularly in the lower leg, forearm, or thigh. Signs: pain out of proportion to the injury, swelling, and tense compartments. Paresthesia or pulselessness may indicate neurovascular compromise. Management: immediate surgical fasciotomy is required to relieve pressure and restore circulation. Relevant guidelines. The ATLS guidelines recommend close monitoring of patients at risk for compartment syndrome, with timely surgical intervention as the definitive treatment. What are the essential components of initial trauma care, particularly in the primary and secondary surveys during trauma life support? ATL. Answer: the primary survey involves the ABCDE approach: airway, breathing, circulation, disability, neurological status, exposure. The primary survey is performed to identify and address life-threatening conditions immediately. Primary survey: rapid identification and management of airway obstruction. breathing difficulties, e.g. tension pneumothorax and circulatory shock secondary survey. Once the patient is stabilized, a more thorough head-to-toe examination is performed, including history taken using the SAMPLE acronym and diagnostic tests, e.g. X-rays, CT scans. The relevant guidelines. The ATLS guidelines stress the importance of the ABCD approach and emphasize the need for ongoing assessment during the secondary survey. How does fluid resuscitation in burn management differ from that in other types of shock? Answer: burn shock is a unique form of hypovolemic shock due to fluid loss from the burn wounds and the inflammatory response to injury. The Parkland formula is commonly used for fluid resuscitation in burn patients. Parkland formula. For adults, the formula is 4 kg body weight in Ag x total body surface area TBSA burn. Half of the calculated volume is given in the first 8 hours and the remainder is administered over the next 16 hours. Comparison: unlike other forms of shock where blood loss is the primary concern, burn shock focuses on fluid and electrolyte imbalances caused by massive capillary leak and edema formation. Relevant guidelines. The American Burn Association guidelines provide comprehensive recommendations for the management of burn injuries, including fluid resuscitation. A 55-year-old male patient presents to the emergency department with sudden onset shortness of breath, pleuritic chest pain, and cough. His medical history includes deep vein thrombosis (DVT) 2 years ago. He appears anxious and his blood pressure is 106 mmHg, pulse 110 bpm, and oxygen saturation 88% on room air. A CT pulmonary angiogram confirms the diagnosis of a massive pulmonary embolism. What immediate management strategy should be initiated? Answer: in this case, the patient is presenting with symptoms consistent with a massive pulmonary embolism, which requires immediate intervention to prevent further complications such as cardiovascular collapse. The following management steps should be prioritized. Anticoagulation therapy. Immediate initiation of anticoagulation therapy is crucial to prevent further clot formation. Options include unfractionated heparin or low molecular weight heparin inhalation unless contraindicated, e.g. inactive bleeding, thrombolysis. If the P is massive and the patient is hemodynamically unstable as indicated by low blood pressure, tachycardia, and hypoxia, thrombolytic therapy, e.g. alteplase or ritoplase, should be considered. Oxygen therapy. Due to the patient's low oxygen saturation, 88%, supplemental oxygen should be administered immediately. If oxygen therapy fails to stabilize the patient's oxygen saturation, invasive mechanical ventilation may be required. A risk stratification. The Wells score or D-dimer can help assess the patient's risk for P and guide the decision on the extent of intervention required. Mr. Jones is a 45-year-old man with a history of smoking and mild chronic obstructive pulmonary disease (COPD). He presents to the emergency department with worsening shortness of breath and productive cough over the last 2 days. His oxygen saturation is 90% and he has bilateral wheezing on examination. Chest X-ray shows hyperinflation, but no consolidation. What should be the immediate next step in management for Mr. Jones? Answer: for Mr. Jones, who is presenting with an acute exacerbation of COPD, the following steps should be taken. Oxygen therapy. The first priority is to correct the patient's hypoxemia. However, in COPD patients, oxygen therapy must be carefully titrated to avoid carbon dioxide retention. Target oxygen saturation should be 88.92% to prevent respiratory acidosis from worsened co-retention. Inhale bronchodilators. Short-acting beta-agonists, SOBAs like albuterol, combined with short-acting anticholinergics, e.g. ipratropium bromide, are the cornerstone of treatment. These should be administered via nebulizer or MDR to reduce bronchospasm. Systemic corticosteroids, oral or intravenous corticosteroids, e.g. prednisone or methylprednisolone, should be started to reduce inflammation and improve lung function. The standard treatment duration is typically 5-7 days. Antibiotics. Given Mr. Jones' productive cough and history of COPD, antibiotics may be indicated if there is suspicion of a bacterial infection. This is particularly relevant if he has purulent sputum or signs of infection, e.g. fever, non-invasive, positive, pressure ventilation (NIV). If the patient shows signs of respiratory distress or hypercapnia, non-invasive ventilation, e.g. BiPAP, should be initiated to assist with ventilation and avoid intubation. Relevant guidelines. According to the Global Initiative for Chronic Obstructive Lung Disease, GOLD, the management of COPD exacerbations includes bronchodilator therapy, corticosteroids, and antibiotics when appropriate, as well as oxygen therapy with a target saturation of 88.92%. Gold 2023. 30-year-old female presents to the emergency department with severe dyspnea, pleuritic chest pain, and a sudden onset cough after long-haul flight. She is tachycardic with a heart rate of 120 BPM and her blood pressure is 1/10 of an mHd. A CT pulmonary angiogram confirms a pulmonary embolism. P. What is the most appropriate anticoagulation strategy for this patient? Answer. The most appropriate anticoagulation strategy for a patient with a confirmed pulmonary embolism P depends on the clinical presentation, e.g. hemodynamic stability and any contraindications to therapy in this patient who is hemodynamically stable. The following steps should be considered. Initial anticoagulation. The patient should be started on unfractionated heparin or low molecular weight heparinolylation (WHE). Enoxaparin is preferred in most patients due to its ease of use and better bioavailability. Heparin or LMWH should be initiated immediately after the diagnosis is confirmed, as they act rapidly to prevent further clot formation. Transition to oral anticoagulants. After the initial anticoagulation, the patient should be transitioned to an oral vitamin K antagonist, warfarin, or direct oral anticoagulants. Dokes like apixaban or rivaroxaban for long-term management. DOACs are increasingly used due to their convenience and predictable pharmacokinetics. Monitoring and adjustments. If UFH is used, the patient's activated partial thromboplastin time act should be closely monitored, aiming for a therapeutic range, typically 1.5–2.5 times the baseline. In patients on warfarin INR, international normalized ratio, monitoring is required, targeting a range of 2.0–3.0 for PE. Thrombolysis consideration. If the patient becomes hemodynamically unstable, e.g. hypertension, shock, thrombolysis, e.g. also plays should be considered. This is typically reserved for massive or submassive PE with shock. Relevant guidelines. According to American College of Chest Physicians Act guidelines, LMWH is preferred for initial anticoagulation in most PE cases, with DOACs recommended for long-term therapy in clinically stable patients. Curran et al. 2016. Mr. Martinez, a 65-year-old man, presents with a sudden onset cough, difficulty breathing, and pleuritic chest pain. His medical history includes hypertension and atrial fibrillation. He has no recent history of travel but has a known history of deep vein thrombus (DVT). His oxygen saturation is 86% on room air, and his blood pressure is 90/60 mmHg. A CT pulmonary angiogram confirms a pulmonary embolism. What initial management should be prioritized for Mr. Martinez? Answer. In this scenario, Mr. Martinez is presenting with symptoms of a massive pulmonary embolism P, which requires immediate management. The following steps should be prioritized. Oxygen therapy. Due to his low oxygen saturation, 86%, supplemental oxygen should be administered immediately to address hypoxemia and prevent further deterioration. If oxygen alone is insufficient, consider non-invasive positive pressure ventilation, e.g. BiPAP. If the patient is in respiratory distress, anticoagulation therapy. Initiate unfractionated heparin or low molecular weight heparinolylate immediately unless contraindicated by active bleeding. Heparin is used to prevent the formation of new thrombi. This is the cornerstone of treatment in PE. For patients with atrial fibrillation, as in Mr. Martinez's case, long-term anticoagulation therapy will also be required. Thrombolysis. If Mr. Martinez is hemodynamically unstable, e.g. hypotensive, tachycardic, or showing signs of shock, thrombolysis, e.g. also plays should be considered. This treatment is reserved for patients with massive PE causing cardiovascular collapse. Supportive care. Monitoring vital signs closely and ensuring the patient is adequately supported is crucial. Blood pressure support may be necessary with vasopressors if shock occurs. Relevant guidelines. The American College of Chest Physicians Act recommends the use of anticoagulation as the standard treatment for PE and thrombolysis for high-risk patients with hemodynamic instability. Curran et al. 2016. A 3-year-old child with a history of recurrent respiratory infections presents with stridor, a barking cough, and mild respiratory distress. The child is febrile, and upon examination, inspiratory stridor is noted, especially when the child is agitated. What is the most likely diagnosis and how should it be managed? Answer. The most likely diagnosis is croup laryngotracheobronchitis, which is a common viral respiratory infection in young children, characterized by inflammation of the upper airways. Management. Supportive care. Most cases of croup are viral and self-limiting. Management focuses on supportive care, including ensuring adequate hydration, controlling fever, and minimizing agitation. Nebulized epinephrine. In moderate to severe cases, nebulized racemic epinephrine can be used to reduce airway swelling and improve stridor. This treatment is especially beneficial if the child is in moderate distress or if stridor persists despite initial supportive measures. Corticosteroids. Dexamethasone is recommended to reduce inflammation in the airways. It can be given orally or intravenously. Oxygen therapy. If the child shows signs of hypoxemia or respiratory distress, oxygen therapy should be provided. A 45-year-old male presents to the emergency department with severe chest pain, shortness of breath, and then diaphoresis. His past medical history includes hypertension, smoking, and hyperlipidemia. The CG shows sense segment elevation in leads IINF. What is the most appropriate next step in the management of this patient? Answer. This patient is presenting with symptoms consistent with an acute inferior wall myocardial infarction indicated by sense segment elevation in leads IINF. The most appropriate next step includes immediate administration of aspirin. Aspirin should be administered to inhibit platelet aggregation and reduce thrombus formation. A dose of 160-325 mg is commonly recommended in acute MI. Anticoagulation. Unfractionated heparin or low molecular weight heparin A should be initiated to prevent further clot formation. Reperfusion therapy. The patient should receive reperfusion therapy either via percutaneous coronary intervention (ECI) or fibrinolysis. PCI is the preferred treatment if it can be performed within 90 minutes of arrival at a facility with the necessary resources. If PCI is not available or delayed, fibrinolytic therapy e.g. alteplase should be administered if the patient meets the criteria, IV. No contraindications for fibrinolysis, monitoring and support. The patient should be continuously monitored for signs of arrhythmias and hemodynamic instability. Administer oxygen if oxygen saturation is below 90%. Pain management. Morphine may be administered for pain control and to reduce sympathetic drive. Relevant guidelines. According to American College of Cardiology (AC) and American Heart Association (AHA) guidelines, early reperfusion therapy via PCI or fibrinolysis and antithrombotic therapy are cornerstones of management for acute MI. ACFAHA 2017. Mrs. Thompson, a 74-year-old woman with a history of chronic obstructive pulmonary disease, COPD, presents with increased shortness of breath, productive cough, and wheezing. Her vital signs include a respiratory rate of 24 breaths per minute, oxygen saturation of 89% on room air, and a blood pressure of 145/85 mmHg. She has not been taking her prescribed inhalers as directed. On examination, she has bilateral wheezing and prolonged expiration. What is the most appropriate initial management for Mrs. Thompson? Answer. In this scenario, Mrs. Thompson is likely experiencing a COPD exacerbation characterized by an increase in baseline symptoms e.g. dyspnea, cough, sputum production, and a decline in lung function. The most appropriate management steps include oxygen therapy. Start supplemental oxygen to achieve an oxygen saturation of 88.92% as she is hypoxemic, SPO 89%. Be cautious with oxygen administration in COPD patients as they may rely on hypoxic drive to regulate breathing. Short-acting beta agonists, SOBAs, administer nebulized albuterol, SIBA, to provide bronchodilation and relieve wheezing. Anticholinergics, ipratropium bromide, an anticholinergic bronchodilator, can be added to SABA therapy to provide further bronchodilation and improve airflow. Corticosteroids. Systemic corticosteroids, e.g. prednisone, should be administered to reduce airway inflammation and speed recovery. A typical dose is 40 mg day for 5-7 days. Antibiotics. If there is evidence of bacterial infection, e.g. purulent sputum, antibiotics may be indicated. In Mrs. Thompson's case, if her sputum appears green or if she has fever, antibiotics should be started, e.g. amoxicillin clavulanate or macrolides. Monitor for complications. Monitor for complications like respiratory acidosis via arterial blood gases and arrhythmias. A 25-year-old male presents to the emergency department with sudden onset dyspnea and chest pain. He has a history of deep vein thrombus (DVT) and has recently started a new oral contraceptive. His vital signs include a heart rate of 110 bpm, blood pressure of 106 Hg, and oxygen saturation of 92% on room air. A CT pulmonary angiogram reveals a massive pulmonary embolism. P. What is the most appropriate first-line treatment for this patient? Answer. This patient is presenting with massive pulmonary embolism. P is indicated by the combination of symptoms, risk factors, and CT pulmonary angiogram results. The most appropriate first-line treatments are Anticoagulation therapy. The patient should immediately receive unfractionated heparin or low molecular weight heparin bush to prevent further thrombus formation and manage the acute phase of PE. Given that he is stable but has risk factors for bleeding, LMWHG enoxaparin is typically preferred as it is easier to manage and requires less monitoring. Reperfusion therapy in a massive PE. If the patient is hemodynamically unstable, e.g. hypotensive shock, thrombolysis, e.g. alteplase should be considered. This is a life-saving intervention to dissolve the clot and restore pulmonary circulation. Supportive care. Monitor the patient's vital signs closely and provide oxygen therapy for hypoxemia. Vasopressors, e.g. norepinephrine, may be required if the patient shows signs of shock. Monitoring for complications. Keep the patient under close observation for potential complications such as right ventricular strain, arrhythmias, and respiratory failure. Relevant guidelines. The American College of Chest Physicians Act guidelines recommend anticoagulation as the cornerstone of management in PE, with thrombolysis reserved for massive PE. In unstable patients, Kieran et al. 2016. Mr. Anderson, a 68-year-old male with a history of chronic obstructive pulmonary disease, COPD, presents with worsening shortness of breath and increased productive cough. His vital signs reveal a heart rate of 100 bpm, respiratory rate of 22 breaths per minute, and oxygen saturation of 88% on room air. On examination, he has bilateral wheezing and crackles. What is the most appropriate next step in his management? Answer. Mr. Anderson is presenting with a likely COPD exacerbation characterized by worsening symptoms of dyspnea, productive cough, and hypoxemia. The most appropriate initial steps in management include oxygen therapy. Given his hypoxemia, SPO 88%, supplemental oxygen should be administered to maintain an oxygen saturation of 88.92%. Oxygen should be used cautiously in patients with COPD due to the risk of oxygen-induced hypercapnia. Short-acting beta agonists, SOBAs, albuterol should be administered as a nebulized treatment to relieve bronchospasm. This is the first-line therapy for acute COPD exacerbations to improve airflow. Anticholinergic medications, ipratropium bromide and anticholinergic bronchodilator, should be given in conjunction with SABA to provide additional bronchodilation and improve airflow. Systemic corticosteroids, prednisone 4-mg should be administered to reduce airway inflammation and speed recovery. A typical course lasts for 5-7 days. Antibiotics. If there is suspicion of a bacterial infection, e.g. purulent sputum, antibiotics should be started. Common options include amoxicillin clavulanate or macrolides. Close monitoring. Monitor for signs of respiratory distress and worsening hypoxemia. Consider non-invasive positive pressure ventilation (NIP) if there are signs of respiratory acidosis. Relevant guidelines. The Global Initiative for Chronic Obstructive Lung Disease GOLD guidelines recommend the use of SOBAs, anticholinergics, and systemic corticosteroids for managing COPD exacerbations. GOLD 2023. Mr. Thompson's newborn infant is delivered and found to have a heart rate of 90 bpm, weak cry, and cyanosis. The neonate is not breathing spontaneously and requires resuscitation. What are the immediate steps you should take to manage this situation? Answer. The management of a newborn in need of resuscitation follows a structured approach based on the Neonatal Resuscitation Program (NRP). Initial assessment and airway management. Dry and warm the infant. Immediately dry the infant to stimulate breathing and prevent heat loss. Position the airway. Place the neonate in a neutral position with a slight extension of the neck to maintain an open airway. Ventilation support. If the infant does not breathe spontaneously after the first 30 seconds, begin positive pressure ventilation (PPV). Use a bag valve mask to deliver air to the lungs and improve oxygenation. Heart rate monitoring. If the heart rate remains below 60 bpm after 30 seconds of PPV, initiate chest compressions while continuing PPV. Medication administration. If the heart rate remains under 60 bpm despite chest compressions and PPV, administer epinephrine to stimulate cardiac function.